Okay. So we'll start. No, it's okay. It doesn't matter. It's fine. Good morning. So yesterday's late evening program was quite late, so I can understand audience is still not probably awake. So we are going to talk about very basic, simple things that we see in our OPD practice. And I'm just going to take you through what we do and what we should be doing. So let's get the basic science out of the way because we all know these terms. So we know vesico-ureteral reflux means that the urine returns from the bladder into the ureters up to the kidneys. So primary VUR means that there is VUR without any associated condition that can cause VUR. So that is conditions like valves, neurogenic bladder, or the others. Now we also know that the pendulum has swung very wildly from being very aggressive with vesico-ureteral reflux to today's state where we don't know what to do with the reflux. So the question for the PPT was to treat or not to treat. And I hope we'll get the answers at the end. We know there are 5 grades of VUR. So you have grade 1, which is mild, and grade 4 and 5, which are the most severe forms of VUR with tortuous dilated ureters and the reflux going up to the kidneys. So we are going to go through some of the cases that we see in the clinic with these, with the children having these kind of VUR. I always say children teach us a lot more than what the textbooks do. So let's start off with the first child. So this is and I would like you to answer, doesn't matter what number of audience is there, because this is what you see in your daily clinic day in and day out. And I would like you to answer what you would do. So this is an 11-month-old boy who presents with dysuria and fever for 2 days. He has high-grade fever, is otherwise well in the past, and all the antenatal scans have been perfectly normal. You find nothing on examination, and as your guidelines say, you send a urine test which shows plenty of pus cells and a urine culture which shows E. coli, more than 1 lakh organisms. And this child is treated with antibiotics. Now, as per the guidelines again, you get an ultrasound done which shows bilateral dilatation of the renal pelvis with the ureters also being dilated. You do a creatinine at that time, which is 0.6 milligram percent. And following this, you get an MCU done, which shows grade 5 VUR on the right and grade 4 on the right. So bilateral high grade VUR. The question is, you recommend surgery, send this child to the surgeon. Would you consider deflux? Would you do reimplantation surgery? Would you do any other tests? And when would you do those tests? Okay. When would you do it? So when? No, that's where the problem lies. This talk is not about that. This is 6 months later. Please ignore the guidelines that are telling you 6 to 8 weeks. It's completely wrong. It has to be done at least 6 months later because acute changes can last for up to 6 months to 1 year. Anyway, this talk is not about that. Your answer was right. A DMSA scan is done 6 months later, which shows that the right kidney is small with a poor uptake. The left kidney is normal and the function 2278. So now we come back to the question, reimplant, not a reimplant. Not decided. So we'll come back. We'll come back. Okay. So case 2, this is the second child, Rohan, who had an antenatal scan showing dilated right renal pelvis. A postnatal scan confirmed dilatation in the right renal pelvis, which is 18 millimeters. The child is otherwise well and undergoes an MCU, which shows bilateral high-grade VUR again. This child has never had a UTI. So would you now advise surgery? Would you put on prophylaxis? How long would you give prophylaxis? I'm not addressing all these issues. This is just, by the way, since we are talking about it, I'm just mentioning one line in them because my talk is about something else. Surgery? No surgery? Okay. So he had an EC scan done instead of a DMSA, which showed good function and drainage on the left, but a poor function on the right, which is 10%. Would you now advise surgery or not advise surgery? No, damaged kidney, and still you would not advise surgery. Anyway, so let's move forward. What happened to these children? Both were managed conservatively. Prophylaxis given with only one antibiotic. If it was an infant, now this is a study that is there. I'll tell you the paper. This is my study. For 1 year, if it was an infant, and 6 months, if it was an older child, these children never developed UTIs at all. In both cases, the dilatation settled down by 5 years of age. And today, case 1 is 15 years old with a normal creatinine, a normal protein creat ratio, and a normal blood pressure. Case 2 is exactly the same, 14 years old and has a normal kidney function with no proteinuria. So let's move on to the next one. This is an 11-month-old boy who presented with fever and turbid urine. Urine showed plenty of pus cells. Culture was positive E. coli, treated with antibiotics. Again, underwent the same procedure. Ultrasound showed bilateral dilatation of the pelvis and ureters and bilateral high-grade VUR on the right and left. A creatinine of 0.6 milligram percent and a DMSA done again 6 months later showed diffuse uptake in both kidneys with no scar. So in two inverted commas, passed off as practically normal DMSA, function 52 to 84, 48%. So would you now do reimplantation or not? No, because of what we heard in the first two cases. Now, unfortunately, they said, what did Dr. Deshpande know? So they reimplanted this child, which was completely successful. A repeat MCU showed no reflux. And this child was followed up for the next 3 to 4 years, had no further urine infections, and was discharged from follow-up. What do you think happened to this child? We'll come back to this child later. This is a fourth child, Mitesh, who had antenatal scan showing bilateral renal pelvis dilatation, otherwise completely well. Postnatal ultrasound confirmed the dilatation present on both sides. A micturating cystourethrogram showed bilateral high-grade VUR with no posterior urethral valves. This child was kept on prophylaxis. Ultrasound showed dilatation was worsening on both sides, and an EC scan done showed a fair uptake but slow drainage. This child never had UTIs, but at 11 months of age, the dilatation had progressively increased to 35-40 millimeters. And so he underwent reimplantation of the ureters with a creatinine of 0.4 and a protein creat ratio of 0.9. He also was perfectly fine. He never developed UTIs. So the question is, would you now discharge him from follow-up at 2 to 3 years of age? Why? He's not getting UTIs. So what are you going to do with him? You did reimplantation to stop the UTI. So this is what the present status of both these children is. So case 3 is now 13 years old. The creatinine is 1.4 milligram percent with an eGFR of 45 ml per minute. A protein creatinine ratio is 0.6 on treatment with ACE inhibitors. And the child, when I saw him at 4 years of age, his creatinine was 0.8 and a protein creat ratio was 1.5. Remember, these children have never developed urinary tract infection. The case 4 is 12 years old, same creatinine is 1.3, eGFR is 40, protein creat ratio 0.4 on ACE inhibitors. Now, if I take you to the school and ask you to identify these children, there is no way in the world you will be able to identify them because they are perfectly fit and healthy children attending school. They are diametrically opposite. Case 3 is extremely active, taking part in all sports. Sorry, the other way around. Case 3 is a lazy boy. Case 4 takes part in all sports. But you cannot make out the difference. So let's come back to these symptom parts. When do we get symptoms when your kidney function drops? So if your kidney function, we calculate kidney function as eGFR. We all know that it's calculated as 0.41 multiplied by the height of the child divided by the creatinine in milligram percent. And this should be more than 80 ml per minute after 2 years of age. If your GFR is 80 ml per minute or more, you go through life perfectly normally. What happens if it drops to 70? Nothing happens to you. What happens if it drops to 50? Nothing happens to you. So your kidney function may drop even to 30 ml per minute, but you will still have no symptoms whatsoever. If you are going to wait for symptoms to come up, your symptoms start coming when the GFR is 20 ml per minute. And what symptoms are those? Tiredness, lethargy, which every child who comes to the clinic complains of. So you cannot pick these children up based on those symptoms. And then when you hit 10 ml per minute, it is a catastrophe because they get hematemesis, they get uremic symptoms, and they need dialysis. So if you are going to wait for symptoms to come up, it is extremely late. The only treatment you can offer is dialysis at that stage. And therefore, we need to start picking them up early. I'm going to put up a non-scientific slide later, which I'll tell you something more about. The second part that you need to know about is the urine protein. The fourth child that I showed you a protein creat ratio of 0.9. I can predict at that stage that this child is going to land up into trouble between 10 to 15 years of age. If you're going to wait and look at the urine routine, you're going to be too late to pick it up. Proteinuria is the single most kidney damaging factor. If your proteinuria is nephrotic range more than 1, present for a long time, you will damage your kidneys without any doubt. Even nephrotic range proteinuria will be missed because it's a semi-quantitative test. Based on urine pH and specific gravity, your protein reading changes. So if you have got dilute urine, which these children have, because they have got dysplastic kidneys, they have dilute urine, and therefore the protein reading will read negative where it has to read 4+. If you have concentrated urine, your protein reading becomes higher. If your urine pH is low, acidic urine, your protein reading is low. If your urine pH is high, protein reading is high. And that's why you will miss this proteinuria. What we do know is that if your proteinuria continues unabated, you will drop your GFR at the rate of 4 ml per year. And therefore, all these children will present to the adult nephrologists needing dialysis. They will not come back to you. They will not come back to you. So unless we check it with the urine protein creatinine ratio, you're never going to pick up this proteinuria. And if you actually manage this proteinuria, you can make a difference. Because the second paper which has come out this month, there is another child who had exactly the same history, but presented at 12 years of age because they presented directly at 12. The creatinine was 3. There was no other treatment except dialysis. Now, these two children, it's a very small study, but if you stop the proteinuria, your kidney function remains better. If your GFR is more than 50% at the end of puberty, in the next 10 years, it's very unlikely you are going to need dialysis. It's a big statement. It's a big change. So instead of them presenting at 15 needing dialysis to the adult nephrologist, you will be able to carry on till they are 25 to 40 without needing dialysis. I've got a child who's got reflux. His father is 42 years old. His creatinine is 2.3. He had reflux. So this is what can happen if you can manage them, if you can pick this up early. Now, this is the most unscientific graph that you will ever see, but it's something that we can use to understand. If you have normal kidneys, the blue line is the creatinine. So as you can see, your creatinine, I don't think this works as well. Okay, anyway, you can see the blue line going up. As you grow, your creatinine gradually increases. The green line is a proteinuria, which is about 0.5 to begin with at birth, and then it starts coming down. So by the time you have puberty, it is 0.15 or 0.1. Now, the same thing, unfortunately, if you have got renal dysplasia, the blue line, if your creatinine is a little high to begin with, it actually settles down in the first year because of kidney maturation. So your creatinine, if you're going to rely on creatinine, you're going to miss it because your creatinine will be 0.6 by 6 months of age, which is like any other normal child's. Then when the creatinine starts rising, as you can see, it is very late. Whereas the proteinuria is also high to begin with. The 0.9 that I mentioned actually settled down, but then increased again. But it increases far earlier than what the creatinine does. So what we need, what you are going to see in your clinic is this group, where the creatinine is normal, but they have proteinuria. And unless you pick it up by doing a protein creatinine ratio, you are going to miss all of them. Do you know how many patients start dialysis program in India? Any guess? 5 lakhs. That's an underestimate apparently, because we don't know the actual numbers. Out of that, 1/3, I mean, a lot of them are diabetes, a lot of them are hypertension. These are adults. 1/3 are unexplained renal failure needing dialysis. What is this unexplained renal failure? This is something that has been missed as children. So if we don't pick them up, this is what is going to happen. They are going to end up with adult nephrologists needing dialysis. So if we want to make a difference, this is where we have to start acting. The creatinine, as I said, improves in the first year of life and then rises quite late in renal dysplasia, 10 to 15 years. Proteinuria, on the other hand, will rise earlier. So it may remain normal, and then suddenly you will find that the proteinuria started going up because of hyperfiltration. And as I said, GFR more than 50% after puberty has a better prognosis. So irrespective of what grade VUR is present, we need to monitor the kidney function. That is what is more important. Conservative treatment also works. Whether you operate, don't operate, doesn't make a difference whether there is DMSA abnormal or normal. Prophylaxis is only for 6 months to 1 year. Repeated MCUs and DMSAs are not necessary. I'm just going to put up another case to just give you an example of we keep on repeating DMSAs with no aim. What they need is annual creatinine, a protein creat ratio, and a blood pressure. An ultrasound in the first few years of life till the dilatation settles down. None of these children had circumcision done. It is not mandatory. It is done only when they get repeated UTIs. We need to pick up proteinuria earlier and don't get thrown by reports of scarring or 10% function or whatever, because DMSA people do not report dysplasia. They only report scarring. And I didn't deliberately put up these pictures of DMSAs because we only read the reports. We don't look at the pictures. Now, if you actually look at this last one, that will be reported as no scarring. That's not normal kidneys. That is going to land up into trouble later on. So if case 3 and 4 had not had surgery done, what would we have labeled them as? Reflux nephropathy. And that's what is happening today. So I have a child who had failed reimplantation. They did a reimplantation which failed. The parents then elected not to go in for surgery again. And he's now 18 years old and he's perfectly fine. He's never had UTIs, his kidney function is normal, and he has no proteinuria, no treatment. Am I alone? This has been there. Unfortunately, try and find a study that tells you long-term outcome of high-grade VUR. There are no studies. There are a few studies recently which have looked at it as a sidearm. They are not actually looking at it. They are more looking at urine infections. We are so focused on reflux UTIs. We have forgotten what we are trying to achieve in the long term. So this came out long time ago. What they are saying is incidence of CKD or end-stage renal disease 20 years ago was 17 per million population in children. What is it today? 25. It's not gone down. If you have operated 20 years for high-grade VUR, your incidence of CKD and ESRD should come down. It shouldn't go up. We are still saying the same. And that's what they are saying, that the surgical treatment of VUR does not seem to have made a difference to the long-term outcome. And that's what we need to start focusing on. Just to finish off the last case, because this is something that we do practically in our clinics. This is Tanish and antenatal hydronephrosis in the left kidney, which was seen. There were no perinatal problems. On a postnatal scan, it was confirmed that he had dilatation. The AP diameter was 16. He had MCU done, which showed left grade 5 UR, right grade 3 VUR. The reason I put this up is this child developed a UTI after MCU. Okay. And he was treated with antibiotics. Now this child, they advised surgery because he had high grade VUR. Remember, this child never had a UTI. We gave him a UTI by doing an MCU. Okay, because for the next 15 years, he's never had a UTI. What other tests in this child? Now, this child had a DMSA done, which showed a small left kidney with diffuse reduced uptake, and the function given was 20% on the left and 80% on the right. Now, what happened to this child? This child never had a UTI in the next 15 years. But he had DMSAs which were repeated at 4 years, 8 years, and whatever. The left kidney reported in the second DMSA was increased scarring with a function of 16. Remember, it was 20 to begin with. A few years later, when they repeated it again, the DMSA showed increased scarring, 12% function. So the question is this increased scarring, and therefore would you operate on that kidney? If yes, why? If no, why? You heard my talk. So let's try to understand. This child is 15 years old today. He's perfectly normal. He does not have proteinuria. He is a perfectly well-grown child. And he's never had surgery. He's not on antibiotics also. So what we need to understand, it's the natural progression of a dysplastic kidney. If you have got a small kidney, if you have got a big kidney, then the child's weight is 10. Then when the child becomes 50 kgs, which kidney do you think is going to work more? The bigger kidney, the normal kidney is going to work more, the smaller kidney is going to work less. And that's the natural evolution of a dysplastic kidney. So to try and equate that with scarring, that's what I said, a DMSA reports only scarring. They don't understand the concept of dysplasia. It is you who have to make a decision of dysplasia based on your clinical judgment of what is happening to the child. So if this had no reflux, the child would behave the same way. Asians are very prone to having dysplastic kidneys. Just to give you an example, in UK, the population of Asians is probably less than 5%. It is 2 to 3%. And the number of people waiting on the kidney transplant list is more than 50%. We are more prone to diabetes. We are more prone to hypertension. We are more prone to dysplasia. We are just missing them right, left, center. We're just not picking them up. So just a few pointers for your clinic. Don't look at the final report of the ultrasound saying fullness, dilated pelvis. Look at the objective measurement of the AP diameter. If it is more than 10 millimeters, it is dilated. If it is less than 10, it is normal. If you get a UTI only after MCU, it begs the question, was it really worth it? I'm quite happy to defer an MCU for a longer time when we are not concerned about an obstructive element. So if you think about valves in boys, please do it early. Otherwise, there's no harm in deferring it for a little while. And please don't do repeated DMSA scans without having an aim, because it's only going to confuse you if you don't look at the pictures and just read the reports. And to finish off, anybody guess this? This is a very old movie, Gone with the Wind. I haven't seen it. I'm not that old. But this is the scene, iconic scene where the leading lady asks the leading man. This is the last scene of the movie where she asks, so what is going to happen to me? And his answer, frankly, my dear, I don't care a damn. So to answer the question to treat or not to treat the reflux, frankly, my dear, I don't care. Because that's not what I'm interested in. Whether you operate, don't operate, despite giving you evidence that operation doesn't make a difference, if you still want to operate, it's your choice. But please start looking at this annually, because this is what is going to make a difference to the number of end-stage kidney disease patients in India. We are talking of 3 to 5 lakh patients. So if you want to make a difference, start doing this annually for every child who's got reflux. That's what will make a difference. And start reading DMSs appropriately. Thank you. These are the two papers that are.
Thank you, sir, for your involvement. Any question?
No, either you understood everything or you understood nothing. Sorry, he's asking. Yeah. Which antibiotic? Are you asking which antibiotic? Sorry. Yeah. Yeah, I know. But which antibiotic you're asking, no? Yeah. So the ideal antibiotic for prophylaxis, as was mentioned long time ago, should be cheap, should not change the periurethral flora, and should be easily palatable. So there are very few that actually follow that. The ideal one is trimethoprim, which we don't get as a single agent. So we have to use a combination with sulfa drugs. Nitrofurantoin may be good, but the problem is, please try tasting it. It's a disgusting medicine. Most of the children puke it up. So nitrofurantoin is the other option. In the absence of these two, we have started using cephalosporins. But remember, cephalosporins change the periurethral flora. So it's not an ideal prophylactic agent. So the ideal one would be trimethoprim, but we don't get it. Therefore, we use Septran. Even that is not available. And therefore, we use cephalexin because nitrofurantoin sometimes is available, sometimes is not as a syrup. It's more available as a tablet.
Not getting into problem. For example, you told that creatinine rises or uniprolactate rises. That is after only a certain stage it rises. But any way of by imaging or any other method, thank you.
In fact, no, because that's what I was going to come to when you asked this question. If you look at the ultrasound scan of these children who have got DMSA scans, they have normal sized kidneys. So the size doesn't tell you. It is the function. The normal kidney tissue has been replaced by abnormal tissue, and therefore you see blobs on DMSA. So there are subtle markers, for example, a loss of CM differentiation, brighter kidneys, a DMSA showing a diffuse uptake and not a uniform uptake, even though the function is normal on both sides. Now, these are very subtle things that can be picked up, but it's very difficult. It's not easy. And secondly, more importantly, it's the degree of dysplasia that determines the long-term outcome. So if you have 80% nephrons which are present, you're probably going to go through life without problems till you're 60. 60, everybody gets problems. If you have nephron number which is 20%, you're not going to go through the first 10 years also. It's those where you have 50 to 60% or 70% nephrons that are present. We are interested in picking them up because you can delay the progression of kidney failure. You can push them into adulthood without needing dialysis.
Measurement in the OPD in picking up kidney problems because for a small child to measure blood pressure is very difficult in a OP plans. So can you just throw light upon that, especially in regards to dysplastic kidneys?
I was going to just answer that question in regard to dysplastic kidney. They are never hypertensive because they have dilute urine. They have dysplastic tubules, so they are polyuric. So they will never be hypertensive till they are 15 years of age. So as far as dysplasia is concerned, that's why the problem that we can't pick them up. Otherwise, you would have said do BPs and you will be picking them up very early. You won't. In terms of BP, yes. But why do you need the appropriate size cuff in the arm? Use an adult cuff in the leg. Systolic BP is all that you need for children. The diastolic BP is not that important in children because the blood vessels are not stiff. It's in adults where there is stiffness of the blood vessels that the diastolic blood pressure starts becoming important. So as long as you get a systolic blood pressure by even using the adult cuff in the lower limb and palpating the dorsalis pedis, you should be fine. No, I think if your blood pressure is high, you will need a full workup because children are not supposed to have hypertension. So then it can be glomerular disease, it can be tubular disease. It is very difficult to pinpoint, but it may be non-renal also. So if you have hypertension, that needs to be investigated. The glomerular causes are the commonest one. Post-infectious nephritis. That's the commonest one, which you see outside. Yeah, you want the chronic ones. But renovascular still remains one of the common renovascular ones. So so it'll either be renal artery stenosis. Yeah. Yeah.
A few hypothetical reasons we have children with unilateral grade 4 D bar. One parent decides to go ahead with the UTI prophylaxis, remains UTI free. The other patient does not choose prophylaxis, does not have UTI. Is there a concept of steroid reflex nephropathy wherein both the children are at the same risk of progressive renal injury, or will preventing UTIs help to save some more nephrons?
I think you missed the first part of the talk. That's that's exactly what I said. It makes no difference. In fact, the third child, hypothetical child, will have surgery done, and it will make no difference in all three to the long-term outcome, because it will depend on the number of nephrons. If you're getting repeated urine infections, yes, it may cause damage. But if you're not getting infections, then how does it matter? Reflux by itself will not cause damage. There is a concept, what is it called? Congenital uh, reflux. I mean, that's the recent concept that has come up, that it's present even before birth, and therefore the damage is already done. So what you do afterwards doesn't make any difference.
Case inhibitor, can you tell us how we can protect the kidneys from
Yes, again, that was part of the talk, because if you look at the graph that I showed you, you will have proteinuria coming up much earlier than with your rise of creatinine. So your renal function is normal. So at that stage, if you can prevent hyperfiltration injury, then the likelihood of the kidney function remaining better for a longer time is very high. So we use ACE inhibitors. So what we do is efferent arteriolar dilatation, so that you reduce the amount of blood going through the glomerulus, and therefore you cause reduced intraglomerular hypertension. And that tends to protect you in the long term. The doses required are often very, very small as compared to the hypertensive doses. And that tends to protect them for a long time. Yeah.
One thing is can prevent the recurrent UTI, but it won't prevent long-lasting.
No, even if you operate, you don't operate. If your kidneys are not normal, you are going to have problems in the long term. More important to pick that up rather than running around reflux and trying to fix the reflux.
Thank you.
Okay. Thank you.
The human second speaker, Method Collector, the President-elect of IIT, and my own close friend, and he member 2014 and 15 along with me. Welcome, sir.